I just want to thank the South Central Telehealth Resource Center and the Heartland Regional Genetics Collaborative for inviting me to speak today. But before I begin, just a quick disclaimer. I'm a clinical genetic counselor, and I'm not trained in information technology. So this means I'm not going to be covering details about our equipment or about connections or types of lines or ISDN or other technical aspects of telemedicine. Instead, I'm going to be talking about our experiences developing telemedicine in Hawaii, the data that we've used to evaluate our telemedicine sessions, and finally, just some quick lessons learned from our experiences. So first, some background information. We are part of the Western States Genetic Services Collaborative, and the Western States Genetic Services Collaborative is in red, and it's one of 7 regional collaboratives across the country funded by the Health Resources and Services Administration. Our collaborative includes Alaska, California, Guam, Hawaii, Idaho, Oregon, and Washington. And the purpose of all of the collaboratives is to increase access to genetics and newborn screening services by using a regional approach, such as sharing resources within and across the participating states. And so one way we've chosen to do that in Hawaii is through the use of telemedicine. And so before I really go into our project, I just want to give you a short geography lesson for those of you who have never had the pleasure of visiting my home state. So Hawaii is made up of 8 main islands, and all of the genetic services for the state are located on the island of Oahu in Honolulu, and that's where the red star is. We only have 1 pediatric clinic in the state, and that's located in Honolulu as well. We don't have bridges that connect the islands, and we don't have ferries that go between the islands. This means that the only way to get from a neighbor island to Honolulu is to fly. Now, the average round-trip ticket from a neighbor island to Honolulu is about $200 per person. This does not include taxis, rental cars, parking fees, and other travel expenses. And while some insurance companies, they will pay for a child and 1 parent to fly to Honolulu for a genetics appointment, not all of them will. The Western States Genetic Services Collaborative does help to fund monthly outreach clinics to the neighbor islands, but spots in these clinics, we usually try to reserve them for children who have difficulty traveling, especially on an airplane. And the wait list for these clinics can be as long as 4 to 6 months. So the geography of Hawaii, plus the lack of affordable transportation between the islands, it really creates a barrier for accessing genetic services for our kids. And with these issues in mind, that's why we really decided to develop a telemedicine program with support from the Western States Genetic Services Collaborative. And so we began this program in June of 2006 with geneticists located in Honolulu and with families from 5 neighbor island sites participating. And these are the islands of Kauai, Molokai, and Maui, and 2 sites on the Big Island of Hawaii, Hilo and Kona. And so now, since I'm not sure how much exposure some of you have had to telemedicine, I thought I would just include a few really quick introductory slides about the different telehealth methods. If you already know this information, I apologize in advance, and I give you permission to surf the web for a little bit or do something else for a few minutes, and then come back. You can come back later. So for the rest of you who are less familiar with telehealth and telemedicine, there are really 2 main types of telemedicine methods. The first is called store and forward or asynchronous telemedicine. And in this type of telemedicine, medical data such as MRIs, videos, or pictures are sent to a physician via a secure network. And the physician can then look at the sent data and respond at his or her own convenience. The key to this process is that it's not done in real time. So for example, a pediatrician here in Hilo could send the pictures, lab results, and MRI results of a patient to a geneticist in Honolulu via a secure email system. The geneticist can then review the information and make recommendations back to the pediatrician. Teleconsults via secure email are becoming very common. However, these activities are not always reimbursable. In fact, here in Hawaii, Medicaid requires a patient to be present and participating in the consult in real time for the consult to be considered reimbursable. So the second type of telemedicine is called real-time or synchronous telemedicine. In this process, the patient and physician are present at the same time for real-time interaction. So by this definition, telemedicine consults with a patient could actually count as a type of telemedicine, but by far the most common type of synchronous telemedicine is video conferencing. And that's the type of telemedicine that we use here in Hawaii. So the geneticist and family can see and speak to each other in real time. So the interaction is kind of similar to one that you would have if you're using Skype or FaceTime, but the connection between the sites is secure. The neighbor island sites are located at Department of Health offices on the different islands, and an on-site facilitator, who is usually a Department of Health social worker, sits with the family during the session. They're present to work the equipment, but they also provide a physical professional presence for the family. And we found that it's really helpful to have a clinical professional and not just an IT person present with the family during the session. At the beginning, they're able to greet and welcome the family and provide the first contact the family will have to the telemedicine appointment. And since a lot of families, this is their first time doing the telemedicine appointment, it's really nice for them to have a clinical person or staff member there to help make them feel a bit more comfortable. The on-site facilitator also helps us to read physical cues, and sometimes that can be hard for us to sense via telemedicine. So, for example, the facilitators can tell when a family is confused or when they might need more explanation, and they can prompt us, the specialists, to provide more details or to kind of explain things in a different way. And finally, they can help provide comfort to the family if the session becomes emotional, because, of course, the physical presence really is much more reassuring than a virtual presence. The Honolulu site is located at Kapiolani Medical Center, which is our children's hospital here in Honolulu. A medical geneticist who is employed by Kapiolani and a genetic counselor who is employed by the Department of Health usually staff the telemedicine session. And then the bridge between the two sites is provided by the State Telehealth Access Network, or STAN, at the University of Hawaii. STAN is part of a federally funded program called the Pan-Pacific Education and Communication Experiments by Satellite, or PSAT, which seeks to improve information and communication technology in the Pacific. STAN provides the video conferencing between the neighbor island and Honolulu sites. It provides a connection. And for us, it waives their usual $36 per hour line charge, and we're so grateful for that. And they do that because we're providing clinical services. And so we've been so lucky to develop these wonderful public-private partnerships between the Department of Health, Kapiolani Medical Center, and the University of Hawaii to help sustain our telemedicine activities in Hawaii. Some quick information about our telemedicine visits. We've had a total of 71 visits so far since 2006. All of our sessions are limited to follow-up appointments. And these are mainly to discuss genetic testing results for pediatric genetics patients. And these are families we've already seen in person at either an outreach clinic or a Honolulu clinic. So we have an already established relationship with the families. And the telemedicine session is really just to review the testing results. And we also do telemedicine to discuss abnormal newborn screening results for alpha thalassemia. And for those of you who don't know what newborn metabolic screening and alpha thalassemia is, here's just a really fast lesson. Newborn metabolic screening is done in all 50 states in the nation. So sometime after a baby is born, after about 24 hours of age, their heel is gently pricked and a few drops of blood is collected, and you can kind of see the nurse doing that in the picture here. The blood is then used to screen the baby for a number of different genetic and metabolic conditions. And here in Hawaii, one of the conditions we screen babies for is called alpha thalassemia. Alpha thalassemia is really common here in Hawaii. About 1 in every 42 babies is born as a carrier for this condition. Alpha thalassemia is a blood condition that can cause serious anemia in affected newborns. However, the condition can range from very mild with almost no symptoms to severe with babies and children who have such bad anemia that they require blood transfusions. Alpha thalassemia is also an inherited condition, which means that parents can have other children who are born with the same disorder. So we see families of newborns from the neighbor islands whose newborn screening results suggest they have a milder form of alpha thalassemia. So through telemedicine, we provide education and counseling about the condition. We organize diagnostic testing for the newborn so that we can confirm that the newborn's alpha thalassemia is truly mild and not one of the more severe types. And we also organize testing on the parents if they choose to undergo that so that we can tell them their chances of having another baby with alpha thalassemia and whether that baby will have a mild or severe form of the condition. So as you can see, we've chosen to limit our sessions to those appointments that do not require a physical exam and which only need counseling and education. And we chose to do that because at the beginning, primarily, the equipment on the various neighbor island sites were really different qualities. So we thought that this was the best decision for us. And also by seeing these fairly straightforward patients via telemedicine, it frees up our neighbor island outreach clinic appointments for families with more complex referral reasons. So since the beginning of our telemedicine activities, we've collected several types of data. These include satisfaction surveys from our families, from the medical geneticist, from the on-site facilitator, and from the referring provider. And we also collect data on the cost of each session, provider time, and reimbursement. And then we compare our data to in-person outreach clinics. And so today I'll just present data from our family and specialist satisfaction surveys and our cost, time, and reimbursement data. So for our family surveys, the first question we ask them is what made it hard to get specialty services? The majority said it was the expense of traveling to Honolulu that really created that barrier to getting services. But what we hadn't considered when we first started our telemedicine survey was that over a quarter cited another less obvious barrier. They said that they had to miss work or lose wages in order to, take their child and fly to Honolulu to receive their services. So this is something that telemedicine really helped alleviate because they didn't have to travel. We then asked, what would you have done if telemedicine hadn't been available? And about half said that they would have traveled to Honolulu to get the services. But what was more concerning to us was that about 13% said that they simply wouldn't have gotten the care that their child needed. We then asked patients from both our in-person and telemedicine clinics to respond to several statements using a Likert scale, ranging from strongly disagree to strongly agree. And for this chart, we combined the agree and strongly agree responses. And so this chart shows responses to 3 statements. I was able to have a good conversation with the specialist. The specialist listened and respected the information I provided, and the specialist responded to all of my questions. So as you can see with these statements, we were trying to determine whether telemedicine affected the way in which families and physicians communicated. So we wanted to see if families felt that communicating via a video conferencing unit made it harder to connect with the doctor. And you can see by the responses, there really was no major difference between the telemedicine and in-person outreach clinics. In fact, 100% of the families were pretty satisfied. These statements were, I feel confident in the quality of care provided today. I would recommend this clinic to other families. And overall, I was satisfied with the visit today. And again, families were really satisfied with the telemedicine, and there really were no differences between telemedicine and outreach clinics. We then asked families, after their experiences today, would they still have preferred traveling to Honolulu? And about 82% said that they preferred the telemedicine. One family said, telemedicine helped. There was nothing really new recommended for us, and to travel 8 hours round trip for a keep-in-touch visit is tough and frustrating. Another family said, I was able to ask questions and speak to the specialist one-on-one without having to fly up and finding accommodations. This has been very helpful, and without it, it would have been difficult for us to be seen. So as you can see, satisfaction with telemedicine was comparable to satisfaction with an in-person outreach clinic. And families indicated high levels of satisfaction with both types of service delivery methods. This finding was similar to other studies which found almost universal satisfaction with telemedicine by families. One article suggested that the high levels of satisfaction by families was because if you provide families with a needed service but where there previously wasn't any services, they will express satisfaction with it no matter how flawed it is because, you know, it's better than nothing. So they said they're happy with it because it's better than not having anything at all. Specialists, on the other hand, were a little more discerning. So on the specialist survey, we asked the medical geneticists to respond to similar statements using the Likert scale. And this chart shows responses to the statements. I was able to have an effective conversation with the family. I was able to effectively share the information I needed. And I felt the family understood all of the information I shared with them today. Like with the families, we were trying to assess whether the technology interfered with communication between the family and the specialist. But unlike with the family, the specialists in general ranked telemedicine a little bit lower than in-person appointments. Although the provider satisfaction with telemedicine was still pretty high, it was over 85%, it looks like the use of telemedicine can still kind of somewhat impact communication. However, the percentages between the telemedicine and in-person outreach clinics are still pretty close. And I haven't run statistical analyses on these, so I don't know if the differences are truly significant. So just a quick caveat there. And for these statements, they were, I was able to provide appropriate medical management to the patient. And in this case, the specialist felt equally comfortable providing medical management via telemedicine and in person. The second statement was, I was able to provide good genetic counseling to the family. Here, telemedicine ranked slightly higher than in-person outreach clinics. And this is probably likely because the indications for telemedicine were more straightforward as compared to the referral reasons for in-person outreach clinics, which tend to be a little more complex. So that's probably why telemedicine was more satisfactory. And then the third statement was, I would recommend this clinic to families with the same indication. And here, over 90% of the time, the geneticist would recommend both telemedicine and in-person clinics to the families. So despite being a little bit less positive than the family survey results, the specialist satisfaction with telemedicine was still overall quite good. One of the interesting findings, though, was when we asked the specialists and the families about how they felt the telemedicine equipment worked. And so about 40% of the time, the specialists said the equipment did not work well. And this is primarily during the first few years of our program, during which we were still kind of working out the bugs and the kinks of our equipment. And so the specialist cited like a pixelated image, especially if the family would move too quickly, or a frozen picture where the family was frozen, but we could still hear the audio in real time. They also cited a delay in the audio response. So, for example, the specialist would say something, but it would take 20 seconds for us to hear the family's response back. So that got really distracting. There could also sometimes be an echo in the audio, and sometimes a delay in starting time of up to 30 minutes because of connection or equipment problems. And again, this is primarily in the beginning stages of our program. And about a quarter of the time in the early years, the equipment wouldn't even work at all. But despite the fact that the families were in the exact same appointments as the specialists, only about 17% of the families said the equipment didn't work well. So they didn't seem to be as bothered by the equipment flaws. And even when the equipment didn't work at all and we had to do the consult by telephone, they still expressed high levels of satisfaction. So I think this goes back to the whole it's better than nothing phenomenon, where even if the telemedicine session was flawed, they still were highly satisfied by it because it was still better than not getting the services at all. So the surveys, again, showed a high level of satisfaction among the families, regardless of technical problems. Specialists, on the other hand, tended to be a bit pickier. Although their satisfaction levels were still high, they were a bit more likely to be dissatisfied, and this is similar to other published studies of specialist satisfaction with telemedicine. And that's because specialists are comparing their telemedicine experiences with the gold standard of face-to-face visits. So no matter how good the telemedicine program is, it will always be somewhat lacking when compared to, again, the gold standard of a face-to-face visit. Families, on the other hand, are comparing their telemedicine experiences to not having any services at all. So again, it's the whole it's better than nothing phenomenon. And this kind of really shows how subjective satisfaction surveys can be. And so although it's important to document satisfaction, surveys might not be the best evaluation measure of the success of a telemedicine program. So for us, we decided to measure other more objective data elements, one of which is travel costs. So what we did for outreach clinics was we recorded the costs of all of the different things that went into travel. So airfare, rental car, gas, parking fees, and meals for both the geneticist and the genetic counselor. And for the telemedicine clinic, we recorded mileage because our telemedicine clinic is located off-site of the regular genetics clinic, as well as parking fees, again, for both the medical geneticist and the genetic counselor. And then we also calculated the cost of the clinician time. So we had the geneticist and genetic counselor record the amount of time they spent prepping during the appointment, following up to the appointment, and traveling for both outreach and telemedicine. And again, this is both for the geneticist and the genetic counselor. And then we use the average salaries of each to calculate the cost for the geneticist and genetic counselor's time. And what we came up with was, for us, the average cost for an outreach clinic visit is about $346. And the average cost for a telemedicine visit is about $158. So the telemedicine session cut the costs in half. However, our costs do not include room rental fees, because some places will charge fees for a room rental. It does not include line charges, and it does not include the time of the Department of Health social worker acting as our on-site facilitator. All of these were waived or donated to us thanks to our partnerships, our public-private partnerships. And had we included these costs, it likely would have, it would have increased the cost of our telemedicine activities. Also the travel time for telemedicine obviously was significantly less, and so that really reduced the costs for our telemedicine clinics. So travel time is about 6 hours, up to 6 hours for our outreach clinic compared to only about 10 minutes for the telemedicine clinic. So that really factors into the clinician's time, which factors into cost. And so we were curious about other time differences, and so we collected time data. And again, this included prepping during the appointment, follow-up, and traveling to the appointment for both the medical geneticist and genetic counselor. And we recorded their time separately. And what we found was for the outreach clinic, not including travel, taking that out, the genetics counselor spends an average of about 2.6 hours per patient, and the medical geneticist spends about an average of about 1.9 hours per patient. And for telemedicine without travel, the genetic counselor spends about 1.9 hours per patient on average, and the medical geneticist spends about 1.3 hours per patient on average. So less time is spent on telemedicine by the specialists. Again, this is not including travel time. This is probably because because for telemedicine, most of the patients are being referred to us for routine referral reasons. So the indications are really pretty straightforward and are not usually complex compared to outreach clinic visits. And there are generally no surprises as far as family history or other health issues that will change the diagnosis. and the indications for telemedicine are relatively benign. So we don't need to spend a lot of time prepping the case or prepping for like an emotional reaction or on psychosocial counseling during the appointment, again, as opposed to outreach clinic visits. And initially, we thought maybe telemedicine would take more time prepping because usually we create electronic educational handouts for each family. We then email them to the neighbor island social worker who then prints out the handouts for the family. But again, because the indications or the referral reasons for telemedicine are fairly routine, once we create the handouts, we can kind of reuse them over and over and over again. So we don't need to recreate each handouts for each family for each time we see a family. And of course, when we factor in the travel time, telemedicine will win hands down. However, we do spend significantly more time coordinating telemedicine clinics as opposed to the outreach clinic. So we do have to think about a lot of different things when scheduling the telemedicine clinics. We have to think about the specialist schedule and the schedule of the on-site facilitator. We need to think about whether the rooms are available in Honolulu as well as in the neighbor island, and we have to think of the stand bridge. So, for example, if the specialists and the on-site facilitators are available, but then the room's not available in Honolulu, we then have to go back and pick a new date and kind of start all over again. So much more administrative time is needed to coordinate the telemedicine visits. In fact, it takes about 2 to 3 times longer to coordinate these visits. And depending on how complicated it gets, it can take up to an hour to schedule these. So one of the suggestions that we can make is, if you're thinking about starting a telemedicine program of your own, is to just pick a regular day of the week or a month to do your telemedicine visit and just let everybody know about this date. This is the date we're going to do telemedicine in advance, so you can kind of avoid the hassle of scheduling. We've tried to do this, but because we have so many different sites, it can get a bit difficult to try to schedule a regular day of the week or month for our telemedicine visits in Hawaii. So we still kind of have to go through the whole process of picking a date where everybody's free. As far as reimbursement goes, reimbursement for telemedicine, it can be a really big barrier to sustainability. Regulations for telemedicine reimbursement are generally set by each state. Here in Hawaii, we were able to pass telemedicine legislation in 2009, which requires all health, accident, and sickness insurance plans to cover telemedicine services that can appropriately replace a face-to-face encounter. And our Hawaii Medicaid also allows for coverage of telemedicine if the patient is present and participating. So this does include reimbursement of store and forward telemedicine. And 21 states do have some sort of telemedicine legislation. And so the American Telemedicine Association has a matrix of all state telemedicine policies and legislations that it updates regularly if you're interested in whether or not your state has any policies in place. And when I last checked, their matrix was updated last week Wednesday, so they really do keep it updated. And you can find this matrix by going to their website at www.americantelemed.org. So we tracked reimbursement since the beginning of our activities in 2006. Our geneticists submit their claim with a GT modifier code attached to their CPT code. And looking at the reimbursement pattern, I saw that it has improved over time. So between 2006 to about 2007, the claims were actually usually denied. We didn't get any reimbursement. Starting at about mid-2007, it started to be reimbursed, but not at the same rate as an in-person visit. By about 2009, it was generally reimbursed at an equivalent rate. And when I was first looking at this, I wasn't sure why, but then in preparing for this presentation, I realized that our legislation was passed in 2009, and this likely contributed a lot to why our reimbursement improved significantly. But insurance companies, they also probably needed time to become educated about telemedicine and to become used to seeing and paying for claims related to telemedicine services. And again, just for some background information, Medicaid does give states flexibility in determining whether, what, and how to charge for telemedicine. So some state Medicaids will allow for reimbursement of the facility fee for the family site, for technical support, for transmission charges, so for like line charges, and as well as for equipment. And this can either be incorporated into fee-for-service or reimbursed separately as an administrative cost. However, we haven't tried to reimburse for these costs. But if you are interested in thinking about starting up a telemedicine program in your own state, you should look into your Medicaid rules and see if you can get reimbursed for these expenses. Some of our challenges that we've encountered, as you heard earlier, we had a lot of technical difficulties, especially during the early years of our program. Initially, our Honolulu site was located at a Department of Health office here in Honolulu, and that was because we could connect our Honolulu Department of Health offices to the neighbor island Department of Health offices without any sort of line charges. However, the equipment at the Department of Health is older, and that's why we got a lot of those problems with the pixelated images and the frozen images, the audio problems, the non-functional equipment, and the need to do telephone consults in place of telemedicine about a quarter of the time. And so because of that, with the help of the Western States Genetic Services Collaborative, we were able to forge a partnership with STAN. And so we then switched our Honolulu site to the STAN offices at the University of Hawaii in 2010. They had much better equipment and IT support on site to help troubleshoot any technical problems, and it was just awesome. And it was also easier to schedule because we could schedule both the STAN bridge and the Honolulu room at the same time, so I didn't have to call 2 different places to see if they were available. However, this arrangement, even though it was great for us, it led to our second major challenge, and that was the physical location of the specialists. So some insurance companies refused to reimburse for our telemedicine sessions when they were held at the STAN offices. And that's because they said the specialists had to be located at a clinic site versus an academic site at the University of Hawaii. We thought this was kind of silly because we thought one of the beauties of telemedicine was that it shouldn't matter where you're located, where your physical location is. You should be able to do it from wherever. Hawaii Medicaid does, however, limit the location that the families have to be for telemedicine to specific eligible sites, such as hospitals and rural health centers. However, I can't find any similar restrictions for provider locations. Nevertheless, we did move our Honolulu sites to Kapiolani Medical Center, which is our children's hospital, in 2012, and we haven't had any additional problems with reimbursement. However, this did affect our patient numbers because there was a stretch when we didn't hold our telemedicine clinic as we tried to figure out a solution to our reimbursement issue. And so this kind of leads me to my first helpful hint and suggestion, and that is, if at first you don't succeed, try again. So don't give up when you come up against obstacles. So it took us years, literally years, for us to figure out our system, and we're still kind of working on it. So again, don't give up, because you will come up against obstacles just as we did with our reimbursement problems, and instead try to figure out solutions and think outside of the box. And don't be afraid to think of unique solutions such as public-private partnerships. So for us, especially in a small state like Hawaii, our public-private partnerships have really been key to helping us develop and sustain our telemedicine activities. So again, for those of you who are just kind of thinking about starting a telemedicine program, kind of look around and see who you might be able to partner with to help support your telemedicine efforts. We've had to do a lot of education about the benefits of telemedicine, and this has been really important. We have and are still trying to educate insurance companies to help them understand the benefits of telemedicine and to help with reimbursement. We've had to do a lot of education with other providers. So for example, primary care providers, to help them accept telemedicine, to help them refer patients to us, to help them see that it's really an acceptable alternative to in-person outreach clinics or in-person clinics in Honolulu. And we've also done some education with potential partners to help them see the benefits of partnering with us and to help support our telemedicine activities. As I mentioned earlier, it really helps to set a date and a regular date and time for your telemedicine clinics. And this will help avoid those front-end administrative time and hassles of trying to schedule everything. And finally, it really helps to have a telemedicine champion, so somebody who is a true believer in telemedicine and in the clinic and will help you not to give up. And it also helps if you find a physician or a specialist champion, because they can help with the education, with insurance companies, or with other providers, because it's always nice to have a kind of a doctor-to-doctor communication. And that's about it. I just want to acknowledge everybody and all of the individuals who helped with our telemedicine activities, including the specialists, all of the social workers, and our neighbor island families. And of course, I want to acknowledge our funding source, our HRSA grant. And I just want to thank everybody for listening to me, and I'm happy to answer any questions.